Thank you, and good morning, and welcome to everybody on the phone, um, or online, I guess, is a more accurate statement. And the first thing I want to start off with is by just conveying uh, many, many thanks to all of you who are attending this webinar today. My understanding is that most, if not all of you, are healthcare partners or caregivers to people who have Parkinson's. And certainly, as a professional caregiver, I know what a toll that can be to care for somebody with Parkinson's. And I really want to thank you on behalf of a grateful province for all of the support that you are giving to your loved ones, because that is support that the province is not necessarily providing. And we are very, very grateful for the contributions that you make to our healthcare system. They are quite profound, as I'm going to talk about in a moment. So I think the technology here, I think, is I advanced the slide, correct?
Yes, that's correct.
Okay, we're going to try that. I tried to advance and it didn't. There we go. Okay. So you're in good company, those of you who are on the webinar. There are approximately 1 million unpaid caregivers in British Columbia. That's almost 1 in 4 British Columbians are an unpaid caregiver to a loved one. Some of those caregivers will be caring for people with Parkinson's. Others will be caring for people who have other conditions and frailties. Quite often it will be a dementia or an Alzheimer's, and as you know, quite often that is a concomitant condition with Parkinson's and can be part of the arc of the Parkinson's disease. Replacing the care that is provided from unpaid caregivers in this province would cost $3.5 billion a year. So the contributions that caregivers make is profound, not just in the economic sense, but I think all of you will recognize that the care you're giving to your loved one, even if it were replaced by professional care, would not carry with it the same level of emotional engagement and attachment that is important for your loved one as you are a co-partner with them on the care journey that you see as we progress through Parkinson's. Caregiver activities can range from giving a ride to the grocery store, medical appointment, assistance with everyday activities such as bathing, toileting, medication management, up to full-time care. And certainly, as most, probably all of you are aware, if you look at the trajectory of the disease, you will start out with lower levels of support as a person begins to develop Parkinson's. And depending on the case, because cases are different, you will find your caregiving, uh, the caregiving needs of your loved one increasing as they continue on the journey. The Office of the Seniors Advocate issued a report in 2017 on caregivers, most particularly caregivers in distress. And I thought I would go through that with you because I think it provides an interesting sense of perspective on the issue and some of the drivers of caregivers in distress. And one of the important things to notice as we go through the findings of the report is that not all caregivers are distressed. Uh, but when we look at it, we can see that those who are experiencing distress could be getting more support than we are providing. Some of that is because of lack of understanding of the care that is available, and part of it is that we have not created a system of support for our caregivers that is working in, in some of the situations. So we looked at the approximately every year we have about 40,000 British Columbia, for the most part seniors, who are receiving home support. And many of our home support clients will have a diagnosis of Parkinson's, and they will often, as you know, have comorbidities with other conditions. The one that we see most commonly is a dementia or an Alzheimer's developing along with the Parkinson's symptoms. 31% of those home support clients have a caregiver who's in distress. And that's significant because when we have categorized a caregiver as being in distress, we have reported that that caregiver is effectively at their wit's end. They can no longer cope, and they're not thinking that they can carry on in providing care to their loved one. So it's a fairly significant and a fairly high benchmark when we say a caregiver is in distress. And not surprisingly, we see that 62%, so more than half of the people who are admitted to long-term care had a caregiver in distress prior to the resident's admission. And so one of the outstanding questions is, okay, if we had been able to ameliorate that caregiver's distress, would we have been able to either delay or prevent that admission to a long-term care facility? Pardon me. And the report also made recommendations on the need to improve supports for caregivers, including our adult day program and our respite beds and our home support. And indeed, we've seen some progress, certainly around adult day programs, based on the findings of that report. So how are we doing when we look at the supports we provide for caregivers? Not very well. So as I said, we find that 31% of our caregivers are in distress. And when we look at, okay, what supports are we giving to these caregivers who are in distress? Interestingly enough, 20% of clients who have a distressed caregiver are receiving less than an hour a day of home support. 43% are receiving an hour but less than 2 hours. So this will be somebody who gets an hour, maybe an hour and a half, but not 2 hours a day of home support. So you've got 63% of home support clients who have distressed caregivers receiving less than 2 hours of home support a day. And what's important to understand is that when we look at our allocation of our resources, we use the magic number of 4 hours a day as the tipping point, for want of a better term, of where, from the health authorities' perspective, it makes more sense for a person to start looking at living in a congregate setting like long-term care versus receiving the home support at home. 18% get less than 3 hours, so they get more than 2, or they get probably about 2 hours. Some of them will get 2.5 hours. And 10% get less than 4 hours. Only 9% of our home support clients who have a distressed caregiver are getting what we call the standard maximum of home support hours, which is 4 hours or more. And so that's very interesting because that shows us that there's a lot more support we could be giving for these distressed caregivers than we are currently giving. We looked at the MAPLE 4 and 5 scores. Now, most people who have a diagnosis of Parkinson's will develop what we call the MAPLE score of 4 or 5. And that's an algorithm that we use. We take the inter-eye assessment, which has about 300 charted observations in it, and we roll up all these charted observations into a variety of different scores. One of the ones we use the most is what we call the MAPLE score, and it is a scale of 0 to 5. So it's a 6-point scale. MAPLE 4 or 5 is effectively a person who would be eligible, based on their condition, for placement in a publicly funded long-term care bed in the province. So that gives you some idea of what we're talking about here. Overall, about 50% of our home support clients are MAPLE 4s and 5s. So what is very interesting to see is when we look at the levels, when you're at level 4, the difference between those who are distressed and those who are not distressed is not a wide margin. But when we look at the very high end at Maple 5, we find that 31% are distressed and 10% are showing no distress. And this is of the overall clients, not just in the Maple 5. So that's why it's not summing to 100%. And so that is telling us, again, when we looked at how many hours of home support were we providing to people at Maple 4 and 5, we found that we were only providing the 4 hours or more to overall about 10% of our what we would call our Maple 5 clients. So that's very significant. I mean, these are a bunch of numbers swirling around. I can appreciate that, but when you look at these, when you look at what are we actually delivering, you realize we are falling far, far short of delivering the support the system is set up to deliver to caregivers in distress. The system is set up to be able to support caregivers and deliver a maximum of 4 hours a day to clients. And reason would dictate that we would be providing the 4 hours a day to clients with the highest acuity, which would be our Maple 4s and 5s. And so you will often hear us talk about we want to keep people at home, we want to support people at home, we have a better at home philosophy, we have all these policies in place, but the practice is falling short of the policy. That's when you look at the numbers, what is clearly happening. And these numbers are matching what people are telling us in a narrative form. So we're all aware it's always a challenge. You hear one person's story and it's one person's story. So they talk about how their frustration with home support, they couldn't get the hours that they wanted, they couldn't make the program fit, and the decision makers are respectful of hearing that person's story, but the response is, well, you know, our system is set up to support people at home, and our system is designed to deliver up to 4 hours a day, and we hear all of that. And so it's assumed that that case is an isolated example. In fact, it's not an isolated example. Very clearly, we could be doing a lot more than we are doing to support people, particularly caregivers and especially distressed caregivers, to support their loved ones and keep them at home for as long as possible, which is what most people want and what most caregivers want for their loved ones. And that includes people with Parkinson's, particularly those who develop quite severe presentation of the Parkinson's disease. The adult day program, on this we have seen a little bit of positive movement in the last couple of years. So adult day program, for those of you who do not know about it, and some of you might not because your loved one has not developed yet to the point where they would benefit from adult day program, but adult day program is where a person goes to a site called an adult daycare site, and they spend the day there. And they will get lunch. Sometimes they'll have lots of activities and interaction. Sometimes there'll be a community bathing program there. They can get bathing. Oftentimes there'll be podiatrists there to look after nails. There can be a physiotherapist there. Sometimes there'll be an occupational therapist there to make sure the seating is correct in the wheelchair, et cetera, et cetera, et cetera. And most particularly, it gives the caregiver a full day in their own home without the loved one there that they're caring for. And I think we sometimes don't appreciate the burden of caregiving, where we think, okay, we can come in and you can go and leave for 2 or 3 hours, but what you no longer are able to enjoy is being in your own home free of the caregiving duties. And with Adult Day Program, when we remove the client, which is what we call the person who requires the care, it leaves the caregiver the freedom to enjoy that home. And I think many of us will understand and appreciate that that's not an insignificant safety valve or relief valve, that if we knew, well, 2 days of the week, or ideally 3 days of the week is where the maximum benefit comes from, I actually will have the full day free, and I don't have to worry about my loved one because I know they're well taken care of, and I don't have to rush out of the house. I can stay home and drink my morning cup of coffee and read my morning newspaper, knowing that the handy dart's going to come and pick up my loved one. They're going to get the company of other people. They're going to get a good lunch, and I know that there's going to be good care provided to them at that Adult Day Program, and I will be refreshed when they come back home at 3:30 or 4 o'clock in the afternoon. It really is something that I think is a godsend for many people who are living with and providing care for loved ones who really can't be left alone for any length of time. Now, we currently have about 114 clients on the wait list, so when you think about how many people there are in the province, that's actually a manageable number. It's increased we've also increased the number of days that we have offered Adult Day Program by 7.2% in the last couple of years. However, there's been a 9.9%. So we've upped the number of days by 7%, but unfortunately, the number of clients has increased by 2%, or by 10%, pardon me. So if you can see that that's going to cause a little bit of pressure on the wait lists. But I think the important signal there is that we are seeing those increases in ADP days, and I think we're going to continue to see more because I think there are a number of additional ADP sites and ADP days that are in the process of opening over the next 12 and 18 months. But there's no doubt that when we look at where is the caregiving coming from, that in the community, the burden is shifting from the public system supporting people with needs in the community to looking to family members to support the needs in the community. And when the family member is exhausted and can no longer provide that care, then we see hospital admissions and long-term care admissions driven up by that. And I think the question is, okay, are we being a little penny wise, pound foolish here by not creating a more robust system to support caregivers earlier in their caregiving journey in the community, so that that exhaustion that hits either takes longer or in fact doesn't materialize at all because we've been able to support them. So what are some of the characteristics of who we're caring for in our home support program? As you can see, the average age is 82. 20% of the clients have an activities daily living score of 3 or more. That means they have a pretty pronounced inability to perform their activities of daily living independently or even with minimal assist. So the ADL goes from 0 to 6, I believe. And so somebody who is an ADL 3 plus is certainly somebody who is unable to what we would call independently ambulate. They can't walk without a walker. They probably cannot sit to stand without some assistance. At 3, they're not going to be in a wheelchair, although they may use a wheelchair to traverse long distances. But in terms of ambulating about in their house, they're probably able to do that on a walker. Somebody would be a 5 or a 6 is where you would start to find people in wheelchairs. The cognitive impairment And as you know, this can be a presenting feature of Parkinson's as it progresses. 21% of our home support clients have moderate to severe cognitive impairment. A person with Parkinson's is, unless there is actually a concomitant diagnosis of an Alzheimer's, they're not as likely to progress to severe cognitive impairment. They're likely to progress from mild to moderate cognitive impairment, just as they are unlikely to progress to severe physical or restricted activities of daily living. They're more likely to progress to moderate, to sort of being in the 3-4 range. But certainly the dividing line here, particularly for caregivers, is when do my activities of daily living and cognitive impairment lead us to a situation where I can no longer be left alone for any period of time, because that's very different from you're comfortable leaving your loved one alone for an hour or two. So you still have that freedom if you need to run to the store for something or go and have a hair appointment or a doctor's appointment of your own. You're okay leaving your loved one alone for 2 hours. They've got the lifeline to press if something goes wrong. At some point, there's a line. Most people don't cross it, but some do, where in fact, no, that is no longer appropriate at all, either because their mobility challenges are such that they simply can't mobilize if there's nobody there, and it's a risk to leave them with nobody, or their cognitive impairment has developed to the point where you no longer have confidence that they wouldn't, for example, elope or wander, and you no longer have confidence around some of the kitchen, leaving the stove on, starting a fire in the fireplace without the once the cognitive impairment is such that you can't have that confidence anymore. That is tipping the balance around caregiving, and we certainly see it around caregiving distress as well. As I mentioned, half of our home support population is Maple 4 or plus. About a third have a diagnosis of dementia. Only 12% have aggressive behavior. You hear a lot about aggressive behaviors. It's a situation both in the community and, frankly, in long-term care where aggressive behaviors do exist, and they are difficult to manage. They're not perhaps as prolific as people think when you start to look at who has actually been charted or diagnosed with aggressive behaviors. What we do find is vast majority of our population has difficulty with medication management. And certainly medication management for a person with Parkinson's is a significant issue. It falls to the caregiving partner. If the caregiving partner lives with the person with Parkinson's, the medication management is simplified. But certainly for people who live alone or whose caregiver does not live with them, the medication management actually can be a significant issue. So who is providing the care? 91% of primary caregivers are family members. So we do find cases where primary caregivers are friends or families, or pardon me, are friends or neighbors of people, but primarily it's family members. Interestingly enough, over half are the adult children. 21% are a spouse. Now, this actually looks a little bit different, not dramatically different, but a little bit different with Parkinson's. We see a higher rate of spousal caregiver with people with Parkinson's than we do adult children. And part of that is a reflection of the earlier age at which you experience the onset of Parkinson's. And so when you're a spouse, one of the issues is you're going to age together. And certainly your loved one who has likely been diagnosed with Parkinson's certainly for someone like me, I would consider a fairly young age, in the 60s and 70s. There are many, 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 many years ahead. And how is the caregiving going to be managed when you as the spouse are of fairly robust health when your loved one is diagnosed with Parkinson's because you're both younger. But as their Parkinson's develops and as you're aging and your ability to continue the level of caregiving that you're providing when in the early stages of the diagnosis, when both the caregiving burden is less and you are more robust, and what does that look like as you both age together? On average, caregivers are providing 20 hours a week of informal care, and as I think common sense would dictate, when the caregiver co-resides, it's 32 hours a week. When they're not co-residing, it's 11 hours a week. And I think that that is what we would recognize. Now, what's interesting, when we talk about what kind of care is being provided, these numbers come out of the inter-eye assessment that we do in home care. So we're very specific about what we allow you to call a caregiving hour. So it's actually caregiving tasks. So unaccounted for in the 32 hours a week the co-residing caregiver provides is things like, I can't leave my spouse, I can't leave my husband alone. So really I'm on duty 24 hours a day. That's not counted in this. When we're asking how many hours of informal care are you providing a week, we're asking you specifically about assisting your loved one in bathing, assisting them in toileting, assisting to feed them, not actually preparing the meal, because the assumption is you're preparing it for both of you. So you can see where 32 hours a week, which is almost a full-time job, and it still doesn't count many of the non-caregiving duties that you're taking on for your loved one, particularly the burden if you're unable to leave them alone. And so there really is quite a burden here being borne by the family caregiver. What increases the risk that a family caregiver is going to be distressed? There's some interesting findings here. Mild cognitive impairment almost doubles the risk. Not severe cognitive impairment, mild cognitive impairment. And I think those of us who have either a loved one in our life or have worked professionally with people with mild cognitive impairment can understand this. And this is what you're most likely to experience with your loved one who has been diagnosed with Parkinson's. And it is the repetitiveness and the slowness of conversations and interactions with your loved one that for the first 40 years of your life together looked very different. And the distress is actually twofold. It's distressing because repeating things, reminding people, can start to weigh on people, and different people have different reactions to this. But it's also the psychological distress of seeing that your loved one is changing, and that where you have gone through your life, particularly those of you for whom it is your spouse who's diagnosed with Parkinson's, you've gone through life together as equal partners, and now the equalness is shifting, and you can see that happening. And certainly, as I reflect on my professional experience, the first thing to note is everybody's different, and every family dynamic is different, and every marriage is different. But certainly, I could see the differences in couples depending on the type of relationship and dependency factors that were there before the development of any illness, condition, or impairment, and how that has to shift as the illness, condition, or impairment continues to increase. Moderate to severe triples the risk. Again, I think common sense would tell us that. Potential or actual problem with depression over doubles the risk. So Another interesting finding, now depression is fairly common, particularly in the initial stages of diagnosis of Parkinson's, and it is also very common in the initial stages of a dementia. And in fact, new evidence is trying to sort through because the presentation of depression and the presentation of dementia, certainly in the early stages of dementia, are almost indistinguishable. Uh, where are we? How much are we attributing some dementias to depression? Are we attributing some depressions to dementia? Again, when you're looking at your loved one as they travel through the Parkinson's journey, to be mindful of what are we seeing here? Are we seeing depression or are we seeing a development of dementia? And we are getting better and better at refining and targeting our diagnosis of dementia so that we are certain to be able to, if something can be treated and depressions can be treated, that we are in fact going down the right diagnostic road to ensure the best treatment. Because caring for somebody with depression, what's interesting is that's a higher risk factor for distress than mild cognitive impairment. And so I think we can't underestimate how debilitating it can be for a caregiver to be living with somebody who is experiencing depression. Dementia, 25% increased risk, and the presence of any behavioral or psychological symptoms is a 75% increased risk. Now remember that most people will not actually have behavioral and psychological symptoms of dementia, and what this is really capturing is these profound personality changes where a person is displaying the aggressive behaviors and is becoming a much different person than they otherwise were. That is not what happens in the majority of cases, but when it does happen, it is a significant increase in risk factor for tipping a caregiver over into being a distressed caregiver. It is one of the reasons for placement in long-term care, and arguably it is one of the issues that is difficult to address in the home environment, that even though their physical care needs may be able to be addressed in the home environment, their behavioral and psychological issues are so profound and are having such a profound effect on their caregiver, and we can't fix those, that it does require a long-term care facility, often a special unit within a long-term care home. And that, unfortunately, is where we see longer wait times than we see for general population beds in long-term care homes. So what are the factors about the caregiver? First of all, the spouses, even though the majority of caregivers are adult children, the risk factor for being distressed is when you're a spouse. And that is because you are more likely to live, to be co-residing is part of it, although a number of co-residing caregivers who are adult children, but you can see the difference there. And this is what many of you are going to have to consider who are caring for your spouse, as I've said before. The diagnosis of Parkinson's on average is at a younger age, and the spouse is younger. And you envision a journey living at home and bringing in those supports, but be very much aware that you are at an increased risk for becoming a distressed caregiver by virtue of being a spouse over being a co-residing caregiver who is not a spouse. So we see there again spouse versus adult child when they are co-residing, and we see how if you're not co-residing, the level of distress is lower. Another interesting finding, and this is something that I would encourage all of you to start thinking about now, is the choices in supports for independent living. So one of the programs that is offered under home support, it's called CECL, it's Choices for Supports in Independent Living. It's effectively it's client direct funding. And so you could be caring for your spouse, for example, and he or she is now requiring about, based on the assessment, about 3 hours of care a day. And there's two routes for delivery of that care. One of the routes for delivery of that care is through your health authority's traditional home support program. So you'll have a schedule and a worker will come in 3 times a day and they'll have a care plan and they'll follow that care plan. The other route is that you can apply for the CECL program and you can get direct funding. I think the current rate is somewhere in the neighborhood of $32 an hour. So what you're able to do is, let's say your loved one needs the 3 hours a day. You would get 3 hours a day times $32 an hour, which is the CECL payment. So you would get, what is that, about 96, I think, $98 a day. And you would be able to decide how you wanted to provide the caregiving with that money. You would be able to hire somebody directly. And there's two things that happen. The first thing is you can usually stretch more hours because the $32 an hour, you're not paying somebody, you can $32 an hour, you can probably get more hours in the day. In part, you may be able to put a little of your own money there and then you can stretch that out. The other thing is when they're your employee, you're able to direct. When you get the help through the health authority, you have to tell one person what it is you need. They construct a care plan. The care aide who comes into the home takes their direction from the care plan. They don't take their direction from the family. And that causes, I think, some tensions and some stresses. And in fact, we find that when we look at the inter-eye data around distressed caregivers. Caregivers of clients who are in the CECL program have a 50% lower risk of caregiver distress, even though the person they're caring for, on average, has a higher level of complexity and complex care needs than the general home support population. And so that's really around the ability, the whole autonomy that comes from self-directing and the ability to meet your loved one's needs and your needs as a caregiver. And so those of you who have started what I would call a relationship with the health authority and have started to plan or are receiving care, start to think about the CECL program and whether that would be appropriate for you. Additional support, but beyond the increased service levels. Okay, so we can say we need to make home support more available. We need to make more adult day programs available. We need to get more caregivers lined up on the CECL program. Okay, but what more can we do? One of the things that the research is showing, and this comes out of BC Caregivers, which comes from more international research, is that identifying yourself as a caregiver earlier is key to developing both the coping strategies and also the support systems that you need. So what we find is that this is particularly true of spouses and to a lesser degree adult children who are performing functions without recognizing that they're a caregiver. They are thinking, I am doing this because this is my duty as a spouse. There's a difference, however, when we're doing something in our duty as a spouse for a temporary period of time. So my husband goes into the hospital, my husband has a surgery, he comes home from the hospital, he has to convalesce. So for a period of time, I have to bring him the breakfast in bed and I have to help him up to the bath. But he's going to get better and he's going to return to his robust self. That's a different issue, and that is arguably a spousal type of role. That is different from, this is now my life. This is now what I do every day, and it's not going to improve. This is the life of a caregiver, not a spouse, a caregiver. And the earlier that we recognize this is who I am, the earlier we will start to potentially connect to support groups, the earlier we will start doing the research around what do I need to do to cope, the earlier we will reach out to our networks of friends and family, the earlier we will develop a plan. And the evidence is pretty clear that if we do that, it will reduce the stress and distress of caregivers going forward, because they have brought in the supports and the network and the coping skills earlier in their journey as a caregiver. Because the other thing, link caregivers with community supports. So the health system is great at, well, it's not great at, but it is designed to provide assistance with tasks. But there's also the support in the community. And, you know, people are different. Not everybody wants or benefits from support groups. Some people find them amazingly therapeutic and amazingly helpful. Other people simply actually want time alone to go for a walk. Other people want to be with other people and not be a caregiver, not talk about caregiving. They want their 2 hours away where they can just forget about their life as a caregiver. That's important for them. That's what works as a community supports. And some people have a melting pot of all those things that are of value to them. But certainly when we look at linking caregivers with community supports, aligning with Caregivers of BC, the Alzheimer's Society of BC are the two that provide the most community connections at the moment. And I think where we need to do a better job is making sure that caregivers are aware of who they need to contact in order to be linked up with those community supports. And then lastly is providing training and education for caregivers so they feel confidence in their caregiving skills. So a very interesting thing, we have a 6-month training course to train care aides who will provide care in the home. The care they're providing, though, when they're not there, you're providing as the caregiver. And so where's your training? And this was identified by the Caregivers Association of BC, that in addition to the supports and the caregivers want to know, how do I do a proper transfer? How do I put on a TED stocking? How do I, some very technical things that they need some training to feel more confidence in those skills. And we have nothing out there to train caregivers in what we call informal or unpaid caregivers. And I think it's a very valid point. And so we're working at trying to develop something that might become available for informal or unpaid caregivers so that they could have some actual task-specific training. So where do we go from here? Certainly from our perspective, we need to increase adult day program access. We've made some gains, and we need to keep going. We need to look at the home support hours. We need to recognize respite, and we need to see a better connection between the healthcare supports through the home support program, linking to caregivers, particularly those in distress, and linking better based on the need of the client from the assessment, that we should be seeing more hours of care for those higher complex clients. We need to improve access to the community choices for supports and independent living, the CECIL program, because we know that it is a very effective way of lowering caregiver distress. We need to reorganize respite beds and increase the capacity of respite beds in the community. And the respite bed is where your loved one would go to a care facility for a week or two and get respite. You don't see that as much, frankly, in the Parkinson's population as we see it in the very advanced dementia population or in the very profound physically disabled population. And lastly, we need to empower caregivers, and that's you. So we need to empower you with the knowledge that you need, with the understanding that you're a caregiver, and we need to empower you to be the voice for what you need to support your role as a caregiver. We have very powerful voices to advocate for professional caregivers. We have very powerful voices that are speaking for the paid caregiving in the community. We need to ensure that the family caregivers have a voice that is heard loud and clear, that has equal power as the voice of the paid caregivers, because going back to the beginning of the presentation, the billions of dollars that the province benefits from the donation of your time really does warrant, I think, better attention than we're giving it. So that's all of my program, and I will now turn it over for questions.
Thank you, Isabel. I think that was really, really informative for folks. I do have a couple of questions just based on the comments people were making throughout the presentation. And if you have questions, please feel free to enter them into the chat box now. So we talked a bit about adult day programs. How would someone go about accessing that program? Would that be through their local health unit or through the health authority? And would they also know where the programs are available?
The answer is yes. What will happen, you call up the health authority, the case manager will do an assessment. She will use the Inter-I to do the assessment. You will become what we call a home and community care client if you're not already. And she or he will be able to tell you what is available in your area, and it's a referral that's made, and you should be given some idea of how long it might take before you're given a day or two. And by given a day or two, I mean you're given a day, you'll be told like you get 1 day of respite or 2 days of respite.
Okay, and then on a similar note, with the Cecil program, I believe you talked about that it would be accessed the same way as the adult day program. Is there a threshold of necessary care before someone can access that program? So, for example, if they only need support, they don't need too much support, would they still be eligible, or would they only be eligible if they're requiring a lot of support?
So the short answer is, in very technical terms, you'd simply have to qualify for home support. But in reality, I think you're going to find that if your care needs are simply a bath once or twice a week, the paperwork required and the setup of Cecil, I think you're going to find you'll get pushback on it. Technically you could, but it doesn't really function that way. It really is most effective for people who have higher care needs because they can bundle those hours. If your care needs are limited, so if it's a bath assist once a week, for example, or 4 hours of respite once a week, you would find, I think, the traditional home support program still pretty effective for that. Again, you qualify for that by calling up the health authority, and they will do a pre-screen on the phone. And then based on that pre-screen, a case manager will come out and assess how many hours of home support you need.
Okay, and just while we're still on the Cecil topic, how does Cecil affect income levels? Is it income dependent?
Yeah, it's the same test as we give for home support. Now, as you know, I've identified this as a problem. British Columbia requires a copayment for home support. Most provinces don't. And the copayment is actually quite high. If you're on the guaranteed income supplement, there's no copayment. If you're not on the guaranteed income supplement, we look at your income and we will require you to pay the first X number of dollars. So to put it in perspective, if you were to get, if you have an income of 28,000 and you were to get a daily visit of home support, we would expect you to pay $8,000 and we would pay whatever was above that. Now, one of the workarounds is that if you're on the GIS, you have no copayment. If you have, or more precisely, if you report any earned income on your income tax return, the maximum amount of your home support payment is capped at $300 a month. And so it can be any amount of earned income. It could be $1,000, it could be $500, it could be $500,000. It's a line on the income tax return. I think it's 236, don't quote me. And if you have any amount of money recorded on that line, you're on the cap. And so what that means in practical terms is you may, based on your income, have a daily rate calculation of $80 a day, which means you pay the first $80 of the billing rate and we pay everything after that. However, if you have earned income, you're capped at $300 a month. So the way that would work is if you receive service every day, you're only going to pay effectively the first 4 days because you're going to pay $80 on day one, $80 on day two, $80 on day three, on day four, $80. Oh, whoops. Now you're just over the $300 cap. That's it. That's the bill you're going to get for the month, and you're going to continue to get service every day after that. So I would encourage certainly any of you who are working, because it's you or it's either the spouse or the client. So we look at both. We look at the combined tax return. So if the spouse is working, no problem. If the client, you can get earned income in any categories. It doesn't have to actually be employment with a T4 slip. It can be self-employment. It can be somebody's paid you to do something, to give advice or something like that. You just have to report an amount on that tax line.
Okay, and switching gears a little bit. So some people in caring roles will encounter a situation where they feel they need support as a caregiver, but the person that they are supporting may resist that. Do you have any suggestions for care partners or caregivers who are in this situation?
Uh, I know the situation that's being described and I have seen it. I'm not sure if it's hundreds of times over my career, but it is certainly dozens of times over my career. And it is, I've seen it both where they don't think the caregiver has issues, and oftentimes that's linked to a lack of insight on their actual care needs, that they don't actually think they need the help. It's a tricky situation to navigate, in part because there are everybody's relationship and situation is a little bit different. And what one person might respond to is different from another person. It is sometimes helpful to involve a third party. So as the case manager, it can sometimes be helpful to discuss with the client the care needs of their partner. Oftentimes I have seen it successful in linking it back to they need to be able to take care of you, and in order to take care of you, they need to have this kind of help or this kind of relief. That can sometimes be effective. But every situation is a bit different, and it's not always easy to resolve, but it sometimes can be resolved. And I have been in situations where you are able to make the client understand the needs of the caregiver, and sometimes linking it back to the client. If your wife doesn't get a break, she's not going to be able to continue taking care of you, is something they understand.
Okay, some good advice there. Um, if a client disagrees with how much support that they're getting through home and community care, what can they do? Is there an appeal process?
Yes, they would. What they would do is go through the chain of command in their local health authority. So the case manager is going to be making the assessment. If you disagree with the hours allocated by the case manager, obviously you take it up to her manager and you keep going. And ultimately, you would be going to the PCQO, the Patient Care Quality Office, and lodging a complaint. And you can see how it would go from there. Sometimes you can ask for a second assessment. I mean, at the end of the day, there's a degree of judgment in these assessments. We're guided by, we make our assessment based on the inter-RI, the HC-RI. So that all sounds very formalized and very objective. But within that inter-RI, there are a number of subjective assessments we're making. One of the biggest subjective assessments we make is the capacity of the caregiver. The whole system is based on um, uh, we are there to provide what the family cannot provide, but the expectation is that the family does provide. So that can sometimes, my assessment of what the spouse can do might be different from my colleague's assessment of what the spouse can do. And that can have not an insignificant impact on the hours of care. So you can ask for a second assessment as well. But the rough guideline is this. Um, the maximum if you're wanting more than 4 hours a day, it's going to have to be some extraordinary arguments because the system really is designed to say that's sort of our tipping point where we say the public will support you to this degree, but after that, either you've got to contribute to the support or we're happy to support you in a more in a congregate setting like a long-term care facility. So, but if you're asking for 4 or less, yeah, that is what the system is there to deliver.
Okay, and I did see a good number of comments here from people who are excited about the idea of training caregivers. And here at the Society, we get questions about that as well. So this is a super exciting idea that I'm really excited to hear about. Um, when and if the training is developed and becomes available, how will people hear about it?
That's a good question. In fact, I've got a meeting this afternoon with BC Care, with the Caregivers Association of BC, and that is one of the items we're going to be discussing. And I think it would be, how it gets developed, and then getting the message out to everybody. And I would think it would be through the Provincial Caregivers Association, Family Caregivers Association.
Okay, great. And last question here, since we do have another minute. Someone was asking, um, their partner is in a care home that's in a different city from where they live. Is there a resource to help them move closer to home?
Yes. So, and in fact, there's been a recent change on how we are assigning people to care facilities. So right now, there is a transfer list. I don't know what health authority you're in, but you would go to the health authority and you would say, I want my husband on the or wife on the transfer list for the facility, meaning the one that's nearer to you. Their name should be put on that in a chronological order, and they should be able to give you some idea of how long it might take before your loved one would be able to be transferred.
Okay, perfect. Um, Thank you so much, Isabel, for taking the time to speak to our group here today. I appreciate all the time you've taken to put the presentation together and all the questions you were able to answer. Um, Before we go today, I just wanted to also mention a few things for our folks here. If you are interested in attending a caregiver specific support group, in some communities throughout the province, we do have those available. So when I send our follow-up email, I will include that information. And we also do have two online caregiver groups as well. one specific to people who are caring for someone in the early to mid stages of Parkinson's, and then one for care partners and caregivers caring for someone in the advanced stages of Parkinson's. In
Okay.
Isabel's presentation, she did touch on depression. So we do have a free short-term counseling program here at the Society, and that program is available both to people with Parkinson's as well as caregivers or care partners of people with Parkinson's. So if the person with Parkinson's is experiencing things like depression or anxiety, or if you as a caregiver are experiencing depression or anxiety or a lot of caregiver stress or burnout, this program is available to you, and I will include details of the program in my follow-up email. And in addition to that, we did produce a caregiver resource a couple of years ago. It's called the Comprehensive Guide for Parkinson's Caregivers, and I will also include a link to that information in my email.
Amy, can I just say one thing? I'm just watching these questions as they're scrolling through. And one person had asked whether there would be a reconsider of the 4-hour maximum, or would we still believe at 4 hours a person would be better off in a long-term care facility? I want to clarify something. It's certainly not my position that someone is better off in a care facility at 4 hours, and I don't think that's the province's position. My position is nobody's going to receive better care than they're going to get at home. The difference, it is a monetary consideration. I think they're going to wrap it. I mean, people like to wrap it around something different. They like to say, well, they need to have other people around them. But the reality is, the blunt reality is, it is of the public resources that are available. Here's what we are paying to support a person in long-term care from the public dollars. And we've said we will spend that amount to support them in the community. And interestingly, over my 25 years, it's always stayed about the same. The magic number is 4 hours a day. And so that's really what drives the decision about looking at providing care in care facilities. I don't think any of us who have practiced would actually believe it's better care in the long-term care facility than at home. There's nothing that's going to be better than a loved one caring for their loved one at home with the proper supports.
Okay, thank you. So that's all the time we have for today, everyone. Thank you again for taking the time out of your busy days to be here. If you have any questions, please feel free to be in touch. And again, I will send a follow-up email with all of the resources I mentioned sometime either late this week or early next week.
Okay,
Thank you.
thank you very much, everybody.
Thank you. Have a good day, everyone.